All right, good afternoon. Thank you all for your patience. We're going to go ahead and get started. We are the Senate Budget and Tax Committee Subcommittee on Health and Human Services. Today is March 4th, 2022. This is the last budget briefing for the subcommittee, so I certainly want to thank our staff here in Budget and Tax for their help and support during this session. Philip, Will, you guys have been with us all session. We thank you for that. I want to thank the members, the Vice Chair of Budget and Tax, Senator Rosapap, one of our veteran members on the Subcommittee on Health and Human Services, Senator Eckert, and we'll be joined by the Senator from Frederick, Senator Young, and certainly we've had some phenomenal presentations from our analysts this session. As always, today we have one budget before us. It's the Maryland Department of Health Medical Care Programs Administration, and our final presentation will be by Ann Wagner. Good afternoon.
Good afternoon. Thank you very much, Madam Chair, members of the committee. So I think it looks like the analysis is all set up on screen, so I'll jump right in. This is the budget analysis for the Medicaid budget. So the allowance provides $12 billion for the Medicaid program in fiscal 23, which shows relatively modest growth of 1.8% or $218 million. By fund type, though, the general funds are what shows a much more significant increase of just under $650 million or 20%, and that's mostly to backfill one-time federal aid related to the pandemic. Moving to the performance analysis section, this first item discusses healthcare quality measures under the Health Choice Program. Exhibit 1 aggregates about 94 HEDIS measures. Those are performance analysis measures that are collected by MDH and are used to evaluate each managed care organization. The bars show the percentage of measures above the national mean in calendar 2019 and 2020. From this chart, you can see that all but one MCO actually showed worse performance in calendar 2020. Only United Healthcare's performance improved slightly by 2.6%. While the drops among otherwise high-performing MCOs are much more significant, moving from calendar 2019 to 2020. The department acknowledged that the COVID pandemic did have an impact on MCO performance, but didn't provide specific reasons for why the large share of measures would have fallen below national averages. Overall, though, Maryland MCOs still reported 62.8% of their measures above the national mean. And so this keeps with historical trends of generally outperforming other health plans nationally. The next item relates to rebalancing, and so that's the state's efforts to rebalance long-term care services from nursing homes or institutional settings to home and community-based services where people can receive services to help them continue living in their homes. From this chart, moving on to this section, the line shows that the share of Medicaid expenditures supporting home and community-based services has gradually increased over the years as additional funding at the federal level has become available for these rebalancing efforts. Most recently in fiscal 21, however, you can see that the COVID pandemic has greatly accelerated the shift to home and community-based services. This is driven by changes in spending for both services, as you're seeing nursing home expenditures fall by just under 10% in fiscal 21. And then also the spending in home and community-based services has increased substantially by almost 26%. And so these trends are heavily impacted by the pandemic, as the disproportionate impact of COVID on nursing homes has reduced nursing home utilization. Exhibit 3 shows this sharp decline in nursing home utilization among elderly adults in fiscal 21. Utilization in fiscal 22 so far has increased very slightly from fiscal 21, and this might be in part due to individuals now entering a nursing home who may have delayed the service at the height of the pandemic. I'll just note that it's still early on coming out of the pandemic, so we're not sure how much the pandemic has, rebased or figured these levels for nursing home utilization and then home and community-based spending. So then moving on to the budget discussion, beginning in fiscal 22, the budget plan includes a $15 million deficiency for an MCO vaccine incentive program. So this would help the state address the slight lag in COVID-19 vaccination rates among Medicaid enrollees compared to the statewide vaccination rate. It was previously reported in November that about 50% of eligible Medicaid enrollees have received at least one dose of a vaccine, compared to about 72% of all eligible Marylanders ages 12 and up at that time, back in November. The incentive program will work by offering payments per fully vaccinated individual ages 12 and up once MCOs reach certain thresholds set by the department. And MCOs have the ability to determine how to incentivize vaccination among their members, but most recently, the MCOs have launched a program that would provide $100 gift cards to fully vaccinated individuals ages 12 and up for being fully vaccinated before the end of this month. At the federal level, the American Rescue Plan also requires that Medicaid programs cover vaccine costs and and the federal government is covering these expenditures with a 100% federal match. The analysis lists some strategies that were proposed by the National Academy of State Health Policy for increasing vaccination rates among Medicaid recipients, and so that's shown on page 14. The department is asked to discuss its progress in implementing these strategies, aside from the MCO incentive program they've announced, and to provide the most recent data on vaccination rates among Medicaid recipients. Moving on to other federal aid that's been made available to the Medicaid program during the pandemic. As has been discussed in other MDH analyses, the state received significant amounts of federal aid through a 6.2% enhanced match applied on qualifying Medicaid expenses. And so that's throughout the National Declaration of a Public Health Emergency. Exhibit 5 shows that across the department, this generated just over $600 million in additional federal funds in fiscal 21, with almost equivalent general fund savings that have also become available to help the state during the pandemic due to these enhanced funds. And then when the fiscal 22 budget was passed, the National Public Health Emergency was set to expire at the end of calendar 21, but has been extended twice so that states will receive the enhanced match through the end of this fiscal year. And so multiple budget adjustments have recognized these additional federal funds, including deficiencies introduced with the budget plan. And then most recently, the supplemental budget added $109 million in federal funds and cut the same amount of general funds in Medicaid to account for the enhanced match continuing through the fourth quarter of fiscal 22. Another source of federal aid for the Medicaid program, a provision in the American Rescue Plan Act, also provides Maryland with an additional 10% enhanced federal match, but that is specifically on expenditures for home and community-based services. The state receives this match on expenditures between April 2021 and then through March 22. But the funds generated from this match are required to be reinvested into home and community-based services to enhance and expand those services. Budget language from last year requires that most of the federal support from this provision be used on a one-time rate increase. And for long-term care providers in Medicaid, that amounts to a 5.2% increase that took effect November 1st of 2021. There was an approved budget amendment that added $78 million to recognize the federal funds that would be claimed on home and community-based services. But the budget plan also, in addition to that, provides $37.8 million to account for the spending on the 5.2% rate increase. And so this double budgets the expenditures on the rate increase in fiscal 22. And so DLS recommends deleting the federal fund deficiency appropriation. The department is also asked to clarify the spending plan for this funding by fiscal year and to provide an update on how the remaining funds other than that rate increase will be used. There is also a second DLS recommendation to restrict funds for administrative purposes until MDH submits a report on home and community-based service expansion spending overall. But then aside from the rate increase, the fiscal 23 budget also provides $12.6 million to expand slots under the community options waiver. And so this was discussed more in depth in the MDH overview earlier this session. But basically, considering recent investments to expand the community options waiver, DLS recommends narrative requesting quarterly reports on expenditures and the waiting list under this program. The last thing I'll highlight in terms of federal aid coming through Medicaid during the pandemic. Recently, it was announced that MDH is providing funding from the American Rescue Plan Act State Fiscal Relief Fund for $25 million in grants to nursing homes, and then $15 million in grants to adult medical daycare facilities. The department has acknowledged in prior budget hearings that there have been delays in processing invoices and distributing grants in other programs. So the department is asked to provide an update on how much of the $15 million for adult medical daycare providers has been distributed, and whether there have been any delays in processing those grants or distributing those funds. And then moving on to a short discussion about the budgetary impact of utilization trends during the pandemic. So this is on Exhibit 6 on page 20. Generally, the pandemic led to lower overall healthcare utilization in calendar 2020, and this led to MCOs spending less than their capitated payments. And so there's normally a medical loss ratio requirement that MCOs spend 85% of their capitated payments. But during the pandemic, it was uncertain whether costs to treat COVID would outweigh their capitated payments, or if the drop in healthcare utilization would create savings and they wouldn't spend up to that 85%. And so CMS allowed states to enter risk corridor agreements with the MCOs mid-year so that any losses or savings from during the pandemic would be shared between MCOs and then the state and federal governments. In calendar 2020, this table shows that 5 MCOs reported low enough spending that the state and the MCOs would split some of their overall savings during that year. And so on this table, you can see that this amounts to about $100 million in total savings to the state and federal governments. And so splitting this between federal and state shares, DLS estimated that this would provide about $35 million or so that would eventually be recouped from MCO payments. And then we would note that the budget currently doesn't reflect these savings. The risk corridor agreements are also in effect for calendar 21 and 22. And so DLS recommends requesting a report on these risk corridor settlements. So that is shown at the bottom of page 20. So then continuing the budget discussion, I'm actually going to skip kind of far ahead in this analysis to page 26. The biggest change in the Medicaid program in fiscal 23 is about $333 million in new spending on provider rates. The rate increases by service type are shown on this Exhibit 10, but just to highlight a few, the mandated 4% rate increase is fully funded for the appropriate providers highlighted on this exhibit. And then the physician evaluation and management rates are raised to 100% of Medicare rates. In past years, the goal has been to keep it at 93% if possible, and this year it's funded at 100%. And then there is also $19.6 million budgeted for a rate increase for dental services. In the past, when there have been rate increases for dental services, it could be targeted only to certain types of dental services. And so MDH is asked to discuss how it plans to distribute that rate increase in particular. And then moving on to a discussion of Medicaid enrollment. So the large spending growth due to the rate increase is partially offset by changes in enrollment and utilization, as the national public health emergency is expected to end in fiscal 23. This is expected to cause enrollment to decline. One of the conditions of the state receiving enhanced federal matching funds throughout the pandemic has been that they can't disenroll any Medicaid recipients, and also that the annual redetermination process has been paused. Exhibit 11 on page 27 shows how the freeze on disenrollment has led to large increases in monthly Medicaid enrollment growth. Especially you can see in calendar 2020, there are some large spikes in monthly Medicaid enrollment growth. In calendar 21, this has leveled off slightly, although enrollment still has been increasing by around 9,000 to 10,000 people each month. I wanted to highlight here that the orange bars at the top here show changes in specifically the Maryland Children's Health Program enrollment. While individuals aren't being completely disenrolled from Medicaid, the department has been moving people between eligibility categories as applicable. And more recently, there has been movement among children in Medicaid from lower income categories to MCHIP, which has a higher income threshold at 300% of federal poverty guidelines. And so as the public health emergency ends, both the DBM forecast shown in the budget and then the DLS estimate, which are outlined in Exhibit 12, expect enrollment to fall in most categories as redeterminations and disenrollment starts back up again. But I did highlight MCHIP enrollment because that is one area where DLS would forecast a continuing increase in enrollment even after the public health emergency, as household incomes may improve and lead children to shift from lower income categories into that MCHIP category. There is a short discussion on pages 30 and 31 on how MDH will resume redeterminations. CMS has provided some guidance to states that allows them to address any backlogs in redeterminations over 12 months after the public health emergency ends. This was just recently updated so that states have 12 months to initiate redeterminations, but they actually have 14 months to complete the process. MDH has indicated that it plans to use the full 12 months to go through the redetermination process, but that it will expedite redetermination in the first few months after the public health emergency for individuals who are more likely to not be eligible, either because they may have aged out of Medicaid services or reported a change in circumstances over the public health emergency that would make them ineligible. And so considering Medicaid recipients haven't been required to certify their eligibility in more than a year throughout this pandemic, MDH should discuss its plan for outreach so that Medicaid recipients know that disenrollment will be starting back up again. And DLS also recommends restricting funds for administration until the department submits a report on the changes in enrollment resulting from redeterminations starting back up again. And then to sum up the budget discussion, expected shifts in enrollment and utilization in fiscal 22 would be covered with the additional federal funds made available because that enhanced match is continuing through the end of the fiscal year. And then in fiscal 23, even though there are slight differences between the DLS and DBM enrollment forecasts, the differences are not expected to have a meaningful cost impact, and so the budget does appear sufficient to cover expected costs in fiscal 23, and there are no recommendations there. I'll briefly go over two issues in this analysis. The first starts on page 33, and it summarizes the programmatic changes that have resulted from the health choice waiver being renewed as of January 1st of this year. Exhibit 14 shows that there are 3 new programs being authorized from this waiver renewal. This includes a 5-year pilot program called the Emergency Triage, Treat, and Transport Model. This will allow for ambulance care teams to be reimbursed for transport to alternative destinations instead of emergency departments. And so this could include urgent care or other alternative destinations. And so this is a pilot program that will be implemented in Annapolis, Baltimore City, and Montgomery County. The next program I'll highlight is under the waiver renewal, Medicaid reimbursement for services and institutions of medical disease, or IMDs, will now be extended to any, institutions of mental disease, will now be extended to any adults ages 22 to 64 with a severe mental illness. Before this renewal, only IMD services for individuals with a secondary mental health diagnosis were reimbursed through Medicaid. So this extends the services that can be reimbursed through Medicaid starting January 1st of this year. And then the last new program is the maternal opioid misuse model. This is actually currently a federally funded pilot in St. Mary's County, but this will be transitioned to a statewide program. And so this program offers case management to pregnant people who are diagnosed with an opioid use disorder. And so this has to do with what was discussed in the MDH overview about increased spending on maternal health and maternal and child health programs. So this is kind of part of that, part of those efforts. And so I won't go over the other changes in the waiver renewal, but some programs here are expanded. And so that can be found in kind of the pages 34 and on those changes. The final issue relates to the value-based purchasing program. This is part of MDH's quality assurance activities for the Health Choice Program. Exhibit 15 on page 37 shows the calendar 2020 performance outcomes among MCOs. The red shows the number of MCO healthcare measures that, it shows the performance outcomes recorded in the disincentive range that would create a penalty. And then the green shows measures in the incentive range that would receive a incentive payment. And so the way the program works is that MCOs receive payments for the measures in the incentive range and then must pay penalties for measures in the disincentive range. Both incentive payments and penalties are capped at up to 1% of the total capitation paid to each MCO. And then the funds generated from penalties fund the incentive payments to the MCOs in this program. In the event that penalties exceed incentive payments, there is a secondary distribution where the top 4 performing MCOs receive bonuses using the excess funds in that secondary distribution. And so Exhibit 15 shows that this structure has led to MCOs that didn't report any measures in the incentive range to still receive net positive payments over $5 million going to to some of these MCOs for being part of the 4 top performing MCOs. And so these recent outcomes and changes, these recent outcomes in addition to changes to federal regulation make it so that this program is being sunset because of a change in federal regulation that requires MCOs to receive actuarial sound rates on an individual basis. So by charging penalties, in some cases, MCOs wouldn't be meeting that federal requirement. And so this program is being sunset or has been sunset as of the end of calendar 21. And instead, the department is now implementing a new population health incentive program. This took effect January 1st of calendar 22. But I'll just note the value-based purchasing program is still included in the MCO agreements in calendar 21. And so MDH is asked to discuss the transition between these 2 programs. The new program, the way that one works is it will be incentive only. And it will allow for MCOs to receive both payments on their actual performance, but then also on improvement, if they can show certain levels of improvement in healthcare outcomes over the prior year. But again, that program will be structured on an incentive-only basis. And so that concludes the issue section. The recommended actions begin on page 40. I'll just highlight item 3 on the bottom of page 41. And then item 6 on the bottom of page 43 are both annual pieces of language that restrict funds in the Medicaid budget from being transferred out or spent on any other uses. Other than those 2 items, the rest of the recommended actions, I believe, have been gone over through my remarks. And so there's one update in this analysis, and then there are 2 appendices that go over some major IT projects. But with that, I'll conclude the presentation, and I'm happy to answer any questions.
Thank you very much. Are there any questions for Ms. Wagner? Dr. Powell would be proud. You did a great job, great job. Thank you very much. All right, colleagues, we are going to turn to the Honorable Dennis Schrader, Secretary, Maryland Department of Health, and his team, including, I think, a good friend who I haven't seen for a while. Good to see you. Mr. Secretary, you can introduce your panel, and we're happy to receive your response at this, your last time before the subcommittee this session.
Thank you, Madam Chair and members of the committee. I'm for the record, Dennis Schrader, Secretary of Health, and I'm joined by Deputy Secretary for Medical Care Programs, Steve Hsu, also our Chief Financial Officer, Emily Brandenburg. Also available for questions are our Medicaid Finance Director, Jennifer McIlvain, Assistant Secretary Yee, and Nick Napolitano. I just want to comment briefly on our Medicaid vaccination program, which we, because of all the effort going back to last summer, we are receiving quite a bit of interest from both regional and national state organizations. We just briefed Region 3 on this program. And from the very beginning, 2 years ago, or a year and a half ago, when we started planning, our focus was on vaccine equity. And we've made quite an effort. Right now, there's about 1.6 million Medicaid recipients, and we've got the managed care organizations who have been working very hard since the fall to increase our numbers. In the analyst report, which I commend, there was a note from our vaccine oversight group in November. There were about 500,000 Medicaid recipients 12 and over who had not been vaccinated through the efforts of the Medicaid program and the MCOs. And we've also got a partnership with the NAACP, Reverend Kobe Little. That's been cut in half. And so we're continuing to drive. The overall numbers are up because a lot of children 5 to 11 have been added, but we're continuing to work on those vaccinations also. But we're very pleased. We're not declaring victory by any means. We still have a long way to go with the COVID challenge, but we are very pleased with the results. So I'm going to turn it over to Deputy Secretary Hsu for, not Deputy, to our CFO, Amy Lee Brandenburg, who's going to answer the responses to the analyst questions.
Thank you, Secretary. Concerning the recommendation to delete the proposed fiscal year 22 deficiencies under Medicaid and MCHIP for the 5.2 HCBS rate increase, with the suggestion that funds were already appropriated through an approved budget amendment, the Department respectfully does not agree with this recommendation. The descriptions of the deficiencies and budget amendment state their purpose is for the HCBS rate increase. However, there are two related items supporting this funding. Number one is the federal funds needed to account for the 10% enhanced match, estimated at $78 million. And the second item is the additional $37 million, which reflects the reinvestment from what we will earn with the enhanced match. Secondly, with respect to quarterly reports on the community options waiver and the CFC program and financial and registry data, we concur, the department concurs. I have a relatively short piece, so for the remainder of this response, Deputy Secretary Hsu will provide our details and positions.
Thanks, Emily. Okay, good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. It's a pleasure to see all of you, and I'd like to express our appreciation for Ann Wagner's good work. She has big shoes to follow and is doing a wonderful job. We were asked to clarify our spending plan for the 5.2% HCBS rate increase for each fiscal year, including the funding levels necessary to get to the 22 numbers, the working appropriation, and the fiscal 23 allowance. And then also to give you an update on any decisions that have been made about the remaining 25% of the funds attributable to the HCBS enhanced FMAP and a timeline by fiscal year for spending those funds. DLS recommended language restricting the funds for administrative purposes within my office until MDH submits a report on accounting for HCBS waiver expansion spending. The department respectfully does not agree with the recommendation. Our CMS spending plan is public, and we update it very regularly. It is on our website. With respect to the remaining 25% of the funds, in the area of DDA.
Mr. Deputy Secretary, I apologize. We're still mask on in the hearing room.
Oh, I'm sorry.
That's
I
okay.
thought during speaking you could come off.
Yeah.
My apologies.
Till Monday.
Thanks, till Monday. Okay, thanks for letting me know. With respect to DDA, the Disabilities Administration, Developmental Disabilities Administration, the department intends to award provider grants with the remaining 25% reinvestment dollars. In the area of behavioral health administration, the department has submitted a request to CMS to implement the coverage of peer support specialists for individuals with substance use disorder. We're delighted about that, by the way, as described in our February 1st, 2022 spending plan update. The estimates to cover this service through March 31st, 2024 will use up all those remaining investment dollars, reinvestment dollars. In the area of long-term care, CMS provided feedback to the department recently that it would not be able to use ARPA monies to fill home and community-based services slots until all its approved slots have been filled. MDH is currently approved for 6,348 slots under the Community Options Program. Through December 2021, MDH had filled 4,456, and we are exploring alternative reinvestment options. MDH was also asked to provide an update on how much of the $15 million in operating grants has been distributed, the status of any delays or processing difficulties slowing the disbursement of funds, and any solutions or strategies that we've implemented to correct invoice processing and grant management issues. As of February 25th of this year, notice of grant awards were released to adult medical daycare providers that will require signature and return to MDH. Once we receive those signed grant contracts, we will begin processing and releasing the grant monies. DLS also recommended adopting committee narrative that requests a report on MCO risk corridor settlements across calendars 20 and 21. We do concur with that, Madam Chair. We were also instructed to provide an update on how the department plans to distribute the dental services rate increase, specifically discussing whether all dental services will receive a rate increase or if the funding will be targeted to certain services. We are planning on targeting all covered dental codes in the proposed fee schedule increase, so it'll be across the board. MDH asked us to discuss current outreach activities and planned outreach activities following the end of the COVID-19 public health emergency to inform Medicaid beneficiaries that redetermination and disenrollment will resume on July 1st, 2022. DLS recommended that the committee add language restricting funds for the purposes of administration until we submit a quarterly report with data and status updates related to the redetermination process. Respectfully, the department doesn't agree with that recommendation. At this point, any quarterly reports with data and status updates would be inaccurate because people's conditions can materially change between now and the end of the PHE. Moreover, the requested information, which is on page 40 of Ms. Wagner's analysis, is not available to the department, nor does there exist a technical mechanism to retrieve the requested information. Maryland has asked CMS to consider national public services announcements helping Americans to understand the upcoming redeterminations. As there is no announced end to the federal PHE, it's difficult to provide accurate information. MDH has been assured that we'll receive 60 days notice from the federal government before the end of the federal public health emergency. Maryland has been very proactive about staying up to date with redeterminations, one of the few in the country, I might add, and has been performing them internally since March of 2020. But no person has been disenrolled based on ineligibility. There are many beneficiaries who've never been through the redetermination process that may need additional communication to help them understand the reasons for the process and the process itself. The state is considering what statewide messaging may be appropriate and when to begin that communication. Lastly, MDH was asked to discuss the transition between PHIP, the Public Health Incentive Program, and VBP, the Value-Based Purchasing Program, particularly in calendar 2021. The PHIP is included in calendar year 2022 MCO contracts. Calendar 21 was still under the old value-based purchasing VBP program. We have prepared a report on that. I believe we have made it available to Ms. Wagner. Happy to get that to you if you need that. It was not specifically requested by the legislature, but we prepared it. HIP will reward plans for both reaching certain targets and for improvements. It's a incentive-only program. We are very eager to implement this program in the current calendar year. Madam Chair, that concludes my remarks.
Thank you very much. Are there
you.
questions from the subcommittee members? Senator Rosapeth.
Got my light on, there we go. Thank you. Good to see everybody. I haven't seen Mr. Shu in quite a while. It's good to see you. I talk with the secretary all the time, actually, so, and Molly, it's good to see you as well. I want to go back to the Medicaid and the vaccines. So we're doing better, but we're always doing better on vaccines because people don't take the vaccines out. There are always more. So I'm trying to get my head around, do you have the stats on the vaccination rates, current vaccination rates or most recent vaccination rates for Medicaid recipients by age group?
Senator, we do have that information. I didn't bring it with me today, but I would be happy to get that to you. And we are seeing continued, material progress.
Yeah, no, that's my impression. I'm glad what
Yes.
you're doing. I know you're committed to it, but I'd really like to see the numbers by age group, because obviously the age group thing affects it because younger kids got access later.
If I could add one thing,
Sure.
Senator. The one thing that you'll see is, and it's not well-known, I believe, the vast majority of our members in Medicaid Health Choice are actually children. And so although we've been keeping up with the adults, now that we're down to 5 to 11, that's a much harder nut to crack. And we're working on it, but you'll see that in the data.
That makes sense. I just got to
Yeah.
get my head around it. So
No.
that was question number one.
Yes, sir.
Question number two is, you've been experimenting with different kinds of ways to move the needle. We've talked about them in the Oversight Committee hearings. Can you give us a little summary of what have you tried that's worked really well, and what have you tried that you tried it but it didn't work?
Generally or within Medicaid?
Medicaid, I'm talking about Medicaid. I'm talking Medicaid. I'm talking Medicaid.
You want to
specifically.
try that? You've
Well,
been doing a lot
a
of the
couple
work.
programs worth noting that I think are illustrative of both sides of your question. We have been trying a $100 gift card
Yep.
program to induce people to get vaccinated. My personal hope was that was going to be a knockout. I was hoping we would see thousands, tens of thousands of people get their vaccinations. Unfortunately, it has been a disappointment. We have seen some progress, probably attributable, to the gift cards, but the percentage of people who've received vaccines and were eligible for gift cards is very, very small. In other words, people got their vaccines, which is great,
I know, but it
but
wasn't.
they didn't get it for the gift card.
No, I understand.
So that one's been discouraging. What has been encouraging is what we've seen as a result of on-the-ground, grassroots, hand-to-hand, working with people to encourage them and educate them about the importance of getting vaccinated. We have initiated a partnership, very excited about this, with the NAACP. And the idea is that we will work with them in targeted zip codes across the state where people are under-vaccinated and where those communities face significant challenges. And with trusted partners, local community figures that are identified by the NAACP, we will reach into those neighborhoods very aggressively, set up pop-up
I understand.
vaccination sites and vans, and get people vaccinated. So very encouraged by that program.
Madam Chair, if I might continue on this a little bit, or you want to go to questions on the other side? Thank you. The trusted partner stuff is something, again, that Secretary and I and Delegate Peña-Melding have talked about ad nauseum for a year and a half, and we saw the huge increase in vaccination rates among Latinos, particularly in that zip code in Langley Park and Adelphi that
Yeah.
Delegate Peña-Melding correctly focuses on. So I think that works, and I think that makes sense. It makes a lot of sense. I don't quite understand how that works vis-à-vis Medicaid, because obviously, some people in a geographic area are eligible for Medicaid, and some people aren't eligible for Medicaid. Does that basically mean you're going to neighborhoods where there are a lot of low-income folks, and therefore a lot of them are on Medicaid? I'm trying to get my head around how this relates to Medicaid.
Could let me, we're actually using data analytics to target, so we know, working with the MCOs, where their members are.
Got it.
And then we compare that to the data we have for, because we know overall through our work with CRISP, that where the under
Yep.
vaccinations are, and then you overlay the two, and that's how they come
Okay,
up
and you, over the zip codes, and that's how you go.
Yeah.
That makes a lot of sense. You mentioned the NAACP, love the NAACP, but that raises the question, what is the ethnic profile of the vaccination rates among the Medicaid population?
We do record that as well, and I will include that in the
You sent- you
information
sent
I'm
it.
going to send to
Great.
you.
Great, thank you very much. Thank you, Madam Chair.
Thank you, Senator. All right, any other questions from the subcommittee members? I just have one. I wanted to acknowledge and appreciated your response to Ms. Wagner's questions about the redetermination and that you're taking a proactive approach. I noticed in your testimony, you talked about the federal government's plans and their notice that they'll give you. I guess I'd just like to hear a little bit more in terms of, you said no one's been disenrolled, and that's fantastic. I guess, are we anticipating, though, what we know is coming on the horizon and doing everything that we can with what we know is coming to make sure that we're prepared? And I think that's kind of where she was going with the request for the quarterly reports, understanding you don't have the information yet. Can you expound on that a little bit, one of you?
I must say, I think we can be very proud of the team that handles this function for the state of Maryland. We have been, we never stopped the process, the monthly process of redetermination. We didn't disenroll anyone because they were ineligible, but we kept going with our routine processes and didn't stop. I routinely get calls from consulting firms, organizations of various kind offering to assist us with preparing for the day when the PHE ends, because their expectation is that we've got a disaster on our hands waiting to happen. And then we explain to them, well, we've been doing redeterminations all along, and they're speechless because they have encountered so few states that have done that. Mm-hmm. So we are in really good shape, and we do expect a material number of people to disenroll when the PHE ends. I don't have any, there's no exact number at the moment, but we do know people have moved out of the state, people have aged out into Medicare, people have happily, their income has increased and they may no longer be financially eligible. And so there will be a substantial disenrollment, and we are concerned about that, and we want to make sure that the appropriate messaging is communicated to Marylanders so that they're not surprised by all of this and understand its reasons and the process that we will be going through to confirm their eligibility.
Excellent. Well, hopefully we can keep communicating on that. We want to help be a part of the solution.
Thank you.
And, yeah, even though we don't think the sky is going to fall, if there's something we can do to help avoid it, we'd sure like to see that happen.
Yes, ma'am.
All right. Senator Rosapat. I know, I do that. Whenever I ask something, it sparks something. Sorry.
No, thank you. No, I am confused about the various deadlines of the federal government as to, we have FEMA deadline issues, we have, I mean, can you give us like the short version of what federal things we're operating under and when they might change? Go ahead, Webster.
Sure. Good afternoon, Senator Rosa Webster Yee, Maryland Department of Health. So there's three principal sets of deadlines that we're focused around. The first is, as this conversation has revolved, there's a federal declaration of public health emergency by the U.S. Department of Health and Human Services. And that is currently, I think, kicked out until about June of this year. But they've been renewing it every 90 days under, the U.S. Health Secretary's authorization. Where it links in with Deputy Secretary Hsu's comments here is they've said, hey, we'll give you 60 days notice, and then the redetermination side kicks in the next quarter. So if the federal government says, hey, we're not going to renew it again, then this could potentially impact in October.
I got it.
So there's a huge
So
timeline.
60 days after the end of the emergency.
Right, but then the public health emergency also impacts a number of scope of practice flexibilities. For example, EMS, paramedics can administer vaccine
yeah.
shots. So that's the Part 2 effects. Then there's the FEMA public assistance deadline, which was announced earlier this week, that they would extend it to July 1st for 100% public match.
Oh, great.
But then going onwards, they've announced that it's a 90% federal match. So those are the two primary deadlines, but there's all sorts of collateral consequence items that are linked into all of this.
No, that's incredibly helpful. One little nuance, well, not a nuance, it's just not based on what they're telling you, but based on what you're hearing and what you think. What is your sense of whether, I guess, 3 months from now, the federal emergency will still be there? What's your judgment? I'm asking for your political
Yeah.
speculation.
You know, to be honest with you, we're still planning for the situation to be in play at some level through the end of December.
That's the question I was asking.
And so we're looking at it both ways. What happened, and we have a sources and uses plan that our Emily Brandenburg is working on. You know, if it goes this way, it means
Yeah.
this, and if it goes that way, because
Yeah.
we're not sure.
Yeah.
We just don't want to get caught
No,
flat-footed.
absolutely, that's exactly right. Thank you very much. Thank you, Madam Chair.
Thank you, and now I'm inspired with another question. So I guess just to kind of follow up on that point then, as this situation is evolving, it seems like it would still be helpful for us to have some touch points and check-in points. And I understand that you didn't love the concept of a quarterly report. We can talk offline. It seems like we ought to stay on top of that and have some moments where we're checking in or know that we can anticipate, even if the update is nothing's changed yet, as we just told you, Madam Chair. So we can talk offline about how maybe to get that. All right. Any other questions from the subcommittee? Well, I'm glad you stepped up, Mr. Yee, so that we can thank you. We've met with you all session as well. Thank you all so much for your testimony, your participation in the process, and wish you all a very safe and healthy weekend.
Thank you.
Colleagues,
You
this
too.
meeting
Thank
is,
you.
we have some testimony here, and we do have several witnesses that have signed up. I almost adjourned us prematurely, but thank goodness I found my document. We have witnesses signed up, and I'll call you in the following order. Dana Kaufman, Joseph DeMattis, Eric Galley. You can come up and be our first panel, and then we have additional witnesses I'll call after this group. Good afternoon.
Good afternoon, Madam Chair. With your permission, would you like me to begin? Madam Chair and members of the committee, Joe D'Amatos, the President and CEO of the Health Facilities Association of Maryland, speaking in support of the budget and offering some context. HFAM has been around for 75 years, and we represent 170 skilled nursing and rehab centers and assisted living centers in Maryland. The majority of those nursing home centers provide the majority of Medicaid center-based care in Maryland. I also want to commend Annalise Wagner for her report. I kind of nerded out on it, and I really appreciate the scholarship that she put into it. And I'd like to offer a little bit of a different perspective really quickly on it, and that is this, that before the pandemic, skilled nursing and rehab centers in Maryland were about 89% full. And that meant that there were 38,000 Marylanders in need receiving quality care in these centers. Right now, they are 78% full. And there's about 22,000 Marylanders. And 70% of those 22,000 Marylanders in skilled nursing and rehab centers today, they live there. They live there full-time. So, Madam Chair, in Communicare in Forestville, or Senator Eckert in Signature at Mallard Bay, or Senator Young at Fundamental Northampton, or Senator Rosapep in the Salva Center at Patuxent River, we're all a place of home for those skilled nursing and rehab residents that have multiple comorbidities and are living in our center. We support the budget because we're very thankful that it includes our 4% statutory increase related to the minimum wage and the fight for 15. Having said that, we're at a critical juncture in the Medicaid funding for skilled nursing and rehab centers in Maryland. We continue to have, as Ms. Wagner pointed out, Medicaid revenues in the cellar and costs through the roof. PPE, staff testing, mostly direct labor costs and agency costs. So we are incredibly thankful for the Hogan administration and the General Assembly to continue the 4% increase. And we're thankful that the governor earlier advanced in 2021 that increase to January of 2021, and that he has made 2 supplemental payments of about $25 million. The reality is that mostly because of those costs that I've shared with you, we're really at a time where we need a structural increase in the base rate. I'll just provide you with 2 more examples and then be open for any questions. So in 2019, before the pandemic, the average CNA in a Maryland nursing home, just base pay, no shift differential, no bonus, no overtime, we're receiving about $16 an hour. In 2020, again, no shift differential, no bonuses, just base pay. In 2020, that was $18 an hour. Direct employee costs are up between 6 and 9%. Agency use has more than doubled, and agency rates have more than tripled. All at a time, as Ms. Wagner says, when revenue, Medicaid revenue to nursing homes has declined by 10%. So with that, I conclude my remarks. I'm open to any questions as the panel continues, and I just thank you all for all that you're doing to support us. Thank you so much, Madam Chair.
Thank you, Madam Chair, members of the committee. For the record, my name is Dana Kaufman. I'm here today on behalf of 3 organizations, Lifespan Network, the Maryland National Capital Home Care Association, and then through Lifespan, the Maryland Association of Adult Day Services. I don't want to repeat what Mr. D'Amato said, so I'm going to take my time and talk really about the home and community-based services that are under Medicaid, that are dealing with the same cost constraints right now. The budget, again, only mandates the 4%, which was put in the minimum wage bill to offset the increases to minimum wage. However, that 4% has now become the floor of what we get. And to be frank, it's just simply not enough. It wasn't enough back in 2018 when Hilltop Institute, as a result of legislation, did a study. That study showed very specifically that there was a cost differential between the cost of care and the reimbursement levels. It's been 4 years, and there has not been any steps taken to reduce that cost differential. And unfortunately, COVID-19 has exacerbated that. We are at risk of losing our home and community-based services right now. For example, medical adult daycare, they're operating right now. They are opened again, but they have been hit very hard. We are very thankful and are waiting for the $15 million to be able to get distributed, but that's going to cover costs that have already been incurred to, keep your mortgage and your lights on in those centers. But those centers are operating right now at 40 to 60% census. And if we're not careful, there are going to be areas of the state that simply won't have that service because they're just not going to be able to continue. That's the same for assisted living. The smaller homes are the ones who take the waiver, but that waiver payment is so low that they simply can't afford to do it anymore. And you're going to see more providers just simply not being able to enroll in that program and provide that home and community-based service. So we are asking that that 4%, that additional monies, because we have a full year on that budget. And I will tell you now, with the cost of inflation and gas and everything else that people are talking about, it hits all of those providers, and they will not be able to keep their doors open if we don't start being able to close that cost differential. Thank you.
Thank you, Madam Chair, members of the committee. My name is Eric Alley, and I'm here today on behalf of the American Heart Association, and I'm actually here to give you all a little Friday afternoon thank you note. The American Heart Association is very grateful that you all passed a bill last year that expands postpartum care for mothers to 12 months, and they think it's going to save a lot of lives, and they think it's going to reduce a lot of heart disease. There's a lot of risk in that period right after when women give birth, preeclampsia and other heart disease, and they really think that we're really going to do a lot of good with this. So they wanted to thank you very much. They wanted to thank the department for putting it into the budget, and of course urge you to keep it in the budget, and just thank you very much.
Well, we're going to receive that thanks. That bill was a recommendation of the President Ferguson's work group on equity and inclusion. Really proud of that bill having passed. Senator Rosapap.
Thank you. I want to ask on the community-based services, you may have said it, but I missed it. Mr. D'Amato's talking about how the revenue is down for the nursing homes by like 9%, I think you said?
10% on the,
10%.
in Ms. Wagner's report, but just as an example, we had 400,000 fewer days of care in Medicaid in one year and then 700 in the other. But go ahead.
I got it, yeah, I think I got it for you, but I'm not clear for the home
Yeah.
folks.
Well, the issue with the home and community-based services is really the fact that the rate has pretty much remained the same. They did get a little bit bump from the ARPA funds, but with census only operating between 40 to 60% right now.
That's what I'm saying. So you're much farther down in terms of bodies than the nursing homes.
Very much so.
That's what I couldn't get my head around. I appreciate that. The other question, Madam Chair, if it's possible, I would love to get the reaction both of Ms. Wagner and of the folks from the department to the general point these witnesses are making about the effect of the crisis in terms of reducing revenue and increasing costs, and just get other perspectives on the points they're making. Is that appropriate?
So Senator, what you're asking is for the secretary to come back up. Let's hear from the analyst.
Yeah, that's
I don't know
fine.
if you have a response, Ms. Wagner.
I mean, I'm trying to look at in the report what page it was, because there is a performance analysis section that talks about nursing home and home and community-based
Right.
expenditures and the differences and how, yeah, nursing homes are down, home and community-based is up. Other than that, I'm not sure I would have any.
I thought you said we were down. That's what I'm
So,
asking.
Madam Chair, can I?
Please,
confused.
the
I'd be
panel.
glad- I'd be
Yes,
glad- I'd be
let's
glad
hear
to
from the
chime in,
panel.
Because actually what Ms. Wagner is reporting and Ms. Kaufman is reporting aligns with sort of the stuff in my written testimony. So
Okay.
I'll just expand a little bit, all right, just a little bit. So because of the enhanced federal match,
Yeah.
and because utilization, people
Yeah.
going to the hospital and then in the nursing homes were down. We'll
Yeah.
start with that first, and then I'll just sort of respond and add on to what Ms. Kaufman said. Because of that, so in 2020, in nursing homes, as an example,
Yep.
to your question, we had about 500,000 fewer days of
Okay.
care, okay? But if you look at Maryland MDS cost reports, which for 2020 have already been audited, you'll find that even though Maryland has a required direct staffing cost ratio of 3 hours directly a day, we were averaging 3.8 or 4 a day and still are. So at a time when revenue for Medicaid was down, our staffing was up,
Right.
and our cost per hour of staffing was up.
Right.
And our utilization of agency staff
Was up.
and all of that. And that's been true of the last 2 years. Now, the money that we got in advancing the 4% January, the 2 additional add-on payments, one that we hope to be getting like literally in the next couple of days, those are super, super helpful.
I know.
But they don't fix a gap on our side of the 10% less paid in Medicaid. And on Ms. Kaufman's side, as she eloquently pointed out, while our occupancy went as far down as like 58, 54, 5%, and is now at 78, which is still 10%
Right, below.
below our average,
Right.
theirs hasn't gone up, and the assistance on their rate hasn't covered that gap statistically as much. So that's the answer. Did I do all right on that, Ms. Wagner?
Senator, did that take care of your question?
It didn't entirely.
Okay,
Okay.
but I don't know that we'll ever take care of your question entirely, but looks like Ms. Kaufman has something she wants to
Okay,
respond.
Fine.
I was just going to add, like, for example, for the medical adult day centers, they were closed for a year.
Right.
And then they were able to reopen, but then unfortunately, while they were getting back on their feet, their Omicron surge hit.
Right.
So some of them actually had to close down because of outbreaks, but frankly, participants
Yeah, didn't
didn't
wanna
want to
come.
come back.
Yeah, of course.
They were too scared.
Right.
So, but you're still trying, so instead of having, 60 people in your center, you've got 20, but you're still running your buses, you still have your staff. I think a lot of people for home and community-based services also turn to home care.
Right.
For their needs. So you could see in the budget analysis, the overall usage of home and community-based services went up, but also those costs for those services went up too, mainly because of the staffing issues.
Right.
So I think that's where you kind of had that dichotomy between home and community-based services going up, but then I'm here saying, but 4% is still an
No,
issue.
I understand your argument on the
Okay.
4%. I was trying to get more at the macroeconomics of it, but we can do
Yeah.
that another time. Thank you, Madam Chair.
Thank you, Senator, and thank you to the panelists. Senator Young.
In a nursing home, what percentage of patients are paying their own way versus those being paid for by Medicaid?
Single digits on average in Maryland, so it sort of changes by region. We have an outlier center in Potomac, which is slightly predictable, that's double-digit private, but generally speaking, you're talking of between 2 and 4 or 5%, very, very small.
Really? In terms of the patients, what percentage do you get from Medicaid versus what a private patient pays?
Oh, I would have to, that would be very regionally based. In some markets, it's tiny, like a single-digit number. In some, it's much higher. I would have to come back and get back to you on that. But it is a very, very, very small percentage of the folks that live or go to skilled nursing and rehab centers, private pay.
Are most on Medicaid when they come in, or do they just come in
Ultim-
until they run out of money? and
Great question. Ultimately, 65, 70% on Medicaid. They call nursing homes their home. And, there's a period of time where people like my mom did before she passed away, they go in, they go out, they go in, they go out. And then they go in eventually, and then 18 months or 2 years later, they die because of the chronic conditions that face them. So, great question. Thank you.
Thank you. Any further questions for this panel? Okay, seeing none, thank you very much for your testimony.
Madam Chair, thank you.
Thank you. We're going to turn to Martha Nathanson, Jonathan Moles, Kristen Bryce, and Peggy Townsend. Come on down.
Start? Thank you.
Sure.
Good afternoon, Madam Chair, members of the committee. I'm Martha Nathanson with LifeBridge Health, a system of hospitals based in central Maryland. And I'm here today to talk about a problem that we face regarding interfacility ambulance transport and how that impacts our capacity needs in hospitals and how it impacts our patients. What happens basically is there are no standards for response time for ambulances that we call to transport patients from our hospital facilities to the right level of care. Once patients are ready for discharge, they need to go to the right level of care. Often that's a nursing home, often that might be at home. And so we call for an ambulance through the process that's set out, and oftentimes that can take hours and days and sometimes up to a week. And my colleague, John Moles here will give you some examples of how that works. I wanted to flag that for you. This is a Medicaid covered benefit, but essentially Medicaid patients are not getting the benefit of this this coverage, because in the end, we end up having to call a private ambulance service for which we pay on our own to the tune of, nearly, for our system, nearly $1 million a year. And patients need to get to that right level of care because under our total cost of care system, it mandates that we get patients to the right level of care at the right time. And one way we can do that is transporting them, interfacility transport, getting them to the right level of care. When the patients are left in a higher level of care, this impact cascades through the health system. So not only is that patient not in the right level of care for their current situation, but that means another patient can't get access to that bed, and that might be a patient waiting in the ER, for example, and then that leads to longer ER waits. And ultimately, this can impact the EMS system because sometimes we have to call EMS to get this transport completed. So I wanted to just set out that problem for you and tell you also that there's good news, and we do want to thank the health department for helping us out during the last few months of the catastrophic health emergency. The good news is this system can work. We just need to figure this out. For about 4 weeks during the end of the catastrophic health emergency, there was relief from the portion of this system that seems to be tying things up, a middleman, if you will, a discharge entity that we have to go through. And for a while, we were allowed to go directly to the ambulance providers. And we wondered when we started that whether the providers themselves would not have the capacity to handle the needs that we had, but it turned out that they did. So that shows us that there is capacity in the ambulance system and that we can make this discharge process work appropriately for interfacility ambulance transport. And with that, I will turn it over to my colleague to share some specific examples to kind of ground this in reality because he deals with this on a day-to-day basis. So thank you very much. Happy to answer any questions.
Good afternoon, Madam Chair and members of the committee. My name is Jonathan Moles. I'm the AVP for Operations for LifeBridge Health. Again, I've been asked to share with you some of the specific challenges that we're having with the Medical Assistance Transportation Program here in the state of Maryland. Specifically, the scheduling of trips with medical assistance leads to pickup delays that are on average triple those of the standards of the commercial ambulance community here in Maryland. It's common to receive pickup times that are 2 and 3 days out into the future, and we often hear no vendor and no crew is actually available. The result of these delays is that the health system is asked to hold patients, as you heard Martha say, causing a longer length of stay and not allowing the hospital to turn those resources over to be used by the next patient. In practice, health systems are not deferring their in practice, health systems are deferring their MA transport volume to their commercial ambulance partners. Outside of the MA process, this comes at a cost to the health system that they bear 100%. At LifeBridge Health, this inability of MA transport to provide reliable, equitable, and timely transport has a financial impact of $80,000 per month to our system alone, just in direct transport costs. In addition, MA transport excludes interfacility emergency transports from our community hospitals into our academic medical centers. This is what the mechanism we use to move our patients from those community hospitals that may not have the service level that the patient needs into those centers where they can receive those life-saving care. That gap in medical assistance transportation benefit is bared by the hospitals who act in the best interest of those patients and quickly and safely move those patients at their own expense. Lastly, I too would like to thank the Secretary for removing the exclusivity component of the contract. Even for that short 3 to 4 week period of time, we did see a very significant improvement in our times for our medical assistance transportation patients.
Good afternoon, Madam Chair, members of the subcommittee. For the record, my name is Kristen Jones-Bryce, and I am the Chief External Affairs Officer for the University of Maryland Medical System. I want to thank Ms. Wagner again for her analysis. She always does such a great job with this, and I know how much time she puts in, so thank you. And I'm going to echo my colleagues' comments and thank the Secretary and also Deputy Director Tricia Roddy and her team. They were really accessible to us through the pandemic and met with us on a number of occasions to help us with this issue. And, I mean, as Martha and John have said, this puts tremendous pressure on our hospitals and on bed availability generally. And when you have a squeeze like we had during the Omicron surge, and we still have in many of our facilities, there's a domino effect. And patients aren't getting the care that they need because we've got patients that can't get out of the facilities that they're in and go to places they appropriately belong. So again, Martha and John have done a great job of articulating the details and the challenges that we face, as has Johns Hopkins in a written statement I know that they have submitted to the subcommittee. I'll just give you a little bit of the UMS perspective. UMS member hospitals exist in 8 jurisdictions across the state. In 4 of those jurisdictions, the local departments contract with only one ambulance provider, a single ambulance provider. The experience, I think, for our hospitals varies between and among the counties. But for perspective, I will tell you in one jurisdiction over a 3-month period from November to January, our team successfully secured needed non-emergency transportation for Medicaid enrollees in approximately 20% of the cases in which we needed transportation. In another jurisdiction, our hospitals have stopped trying to access the program because they have not been successful in arranging transports. As John said, in instances where hospitals are unable to secure transportation, they have to default to private ambulance contracts and receive no reimbursement at all for those expenses. For UMS, these non-reimbursed transports have cost us over $800,000 in FY21. While I think I'm not really prepared to speak for the transport providers, I do understand that reimbursement rates may be part of the problem around participation. On the emergency transportation side, I will tell you that there's legislation in front of the General Assembly this year that would phase up Medicaid reimbursement for local EMS transportation. That bill would also require reimbursement for mobile integrated health services that those teams provide and for diversion of 911 patients to urgent care when that's appropriate. What I will share with you on our side is that we end up paying double or triple the Medicaid reimbursement rate when we have to pay through a private service ambulance company. So that concludes my remarks, and I appreciate your time, appreciate your consideration of our amendment. Thank you.
Thank you, Madam Chairman, members of the committee. Peggy Townsend on behalf of MedStar Health. I'm going to focus on what we are going to ask you for, and that is a study. We have some language in front of you that would require MIMS to study this issue, including the capacity of the ambulance companies. Do we have enough? The reimbursement related to these transports, is that the problem? And then the need for performance standards. We're not suggesting you withhold any money or any of that. We want to just get this fixed. And if we could have a study by MIMS due back at the end of the year, hopefully we'll make some progress on this. So with that, we'd urge you to adopt our proposed language.
Thank you very much. Are there questions for this panel? Okay, thank you all very much for your testimony and your waiting this afternoon for an opportunity to testify. Folks, this is, as I mentioned at the beginning, our last budget hearing for the session. Senator Rosa Pepp, I have it on very high authority that the Secretary and his team, Mr. Yee, will be prepared to follow up with you on the issue that you raised just a moment ago. As we're moving through the budget process, we absolutely want to get answers as quickly as possible so that we can make informed decisions. I want to again thank the witnesses, the Secretary and your team, the analysts, our staff here on Budget and Tax, and certainly the members of the subcommittee. We have had a jam-packed session, and we're just getting warmed up. So thank you all very much. Have a good weekend.
Thank you.